Okay, another conventional antipsychotic, which is Cyamemazine. It has the trade name of uh, Tercian or Tertian, atypical at low doses. So it is, yes, typical or conventional antipsychotic, but it can be atypical at low doses. Popular in France, not available in the US. Let's talk about that. Okay, Cyamemazine, uh, Tercian. It has no generic in USA. The class is conventional antipsychotic, neuroleptic, phenothiazine, like chlorpromazine, dopamine D2 antagonist, serotonin dopamine antagonist also. Okay, let's talk about that. Commonly prescribed for, it's not of course FDA approved because it's not used in USA, but it is used in schizophrenia and anxiety associated with psychosis for short term, anxiety associated with non-psychotic disorders, including mood disorders and personality disorders for short term, of course, severe depression, bipolar disorder, other psychotic disorders, acute agitation or aggression, we can use injections, and benzodiazepine withdrawal symptoms. How the drug works: it blocks dopamine D2 receptor, reducing positive symptoms of psychosis. Although classified as conventional antipsychotic, Cyamemazine is a potent serotonin 2A antagonist. So this is a property of, second generation and atypical antipsychotics. This is serotonin 2A antagonism. So affinity at myriad of other neurotransmitter receptors may contribute to cyamemazine's efficacy. Specifically, antagonists action at 5-HT2C receptors that may contribute to notable anxiolytic effects in many patients. 5-HT2C antagonist actions may also contribute to antidepressant actions in severe depression and to improvement of cognitive and negative symptoms of schizophrenia in some patients. How long until it works? Psychotic symptoms can improve with high doses within 1 week, but it can take several weeks for full effect on behavior. Anxiolytic actions can improve with low doses within 1 week, but it can take several days to weeks for full effects, for full effect on behavior. If it works, high doses most often reduce positive symptoms in schizophrenia, but do not eliminate them. Low doses most often reduce anxiety symptoms in psychotic and non-psychotic disorders. So most schizophrenia patients do not have a total remission of symptoms, but rather a reduction of symptoms by about a third. Continue treatment in schizophrenia until reaching a plateau of improvement. After reaching a satisfactory plateau, continue treatment for at least 1 year after first episode of psychosis in schizophrenia. For second and subsequent episodes of psychosis in schizophrenia, treatment may need to be indefinite. For symptomatic treatment of anxiety in psychotic and non-psychotic disorders, treatment may also need to be indefinite, while monitoring, of course, the risks versus the benefits of long-term treatment. Reduces symptoms of acute psychotic mania, but not proven as a mood stabilizer or as an effective maintenance treatment in bipolar disorder. After reducing acute psychotic symptoms in mania, you consider switching to a mood stabilizer and or an atypical antipsychotic for long-term mood stabilization and maintenance. Okay, what if it does not work? For treatment of psychotic symptoms, you consider trying one of the first-line atypical antipsychotics like risperidone, olanzapine, quetiapine, ziprasidone, aripiprazole, paliperidone, or amisulpride. You consider trying another conventional antipsychotic. If 2 or more antipsychotic monotherapies do not work, you consider clozapine, of course. For treatment of anxiety symptoms, you consider adding a benzodiazepine or switching to a benzodiazepine. Best augmenting combos for partial response or treatment resistance. Generally best to switch to another agent, not to augment, okay? But augmentation of conventional antipsychotics has not been systemically studied. Addition of a mood stabilizer anticonvulsant such as valproate, carbamazepine, or lamotrigine may be helpful in both schizophrenia and bipolar mania. Augmentation with lithium in bipolar mania may be helpful. Addition of benzodiazepines, especially for short-term agitation. Addition of antidepressants for severe depression. Okay, tests. Since conventional antipsychotics are frequently associated with weight gain before starting treatment, weight all patients and determine if the patient is already overweight or obese. Before giving a drug that can cause weight gain to an overweight or obese patient, consider determining whether the patient is already has prediabetes, diabetes, or dyslipidemia. And treat or refer such patients for treatment, including nutrition and weight management, physical activity, counseling, smoking cessation, and medical management. Monitor weight and body mass index during treatment. Consider monitoring fasting triglycerides monthly for several months in patients at high risk for metabolic complications, and when initiating or switching antipsychotics, of course. While giving a drug to a patient who has gained more than 5% of initial weight, you consider evaluating for the presence of prediabetes, diabetes, or dyslipidemia, or consider switching to a different antipsychotic. You should check blood pressure in the elderly before starting and for the first few weeks of treatment. Monitoring elevated prolactin levels for dubious clinical benefit. Patients with low white blood cell count or history of drug-induced leukopenia or neutropenia should have complete blood count monitored frequently during the first few months. And Cyamemazine should be discontinued at the first sign of declined WBC in the absence of other causative factors. Let's talk about side effects. How drug causes side effects. This drug causes side effects by blocking dopamine D2 receptors in the striatum, so it can cause motor side effects there, and at antipsychotic high doses, of course, nigrostriatal pathway. Much lower propensity to cause motor side effects at low doses used to treat anxiety, because it works as second generation actually at low doses. So at high doses, it can cause motor symptoms. By blocking dopamine D2 receptors in the pituitary, it can cause elevation in prolactin. But unlike other conventional antipsychotics, prolactin elevations are, at low doses of cyamemazine are uncommon or transient. Blocking dopamine D2 receptors excessively in the mesocortical and mesolimbic dopamine pathways, especially at high doses, it can cause worsening of negative and cognitive symptoms. We call that neuroleptic-induced deficit syndrome. Anticholinergic actions, especially at high doses, may cause sedation, blurred vision, constipation, and dry mouth, of course. Antihistamine actions may contribute to anxiolytic actions at low doses, but can cause, side effects of sedation and weight gain at high doses. By blocking alpha-1 adrenergic receptors, cyamemazine can cause dizziness, sedation, and hypotension, especially at high doses. Mechanism of weight gain and any possible increased incidence of diabetes and dyslipidemia with conventional antipsychotics is unknown. But for this case, we're talking about H2 blockage and some conventional thing. But it is unconventional or atypical things. Some notable side effects like neuroleptic-induced deficit syndrome, unusual at low doses, but it can happen. So neuroleptic-induced deficit syndrome, it can happen at high doses, of course. Akathisia, extrapyramidal symptoms, Parkinsonism, tardive dyskinesia, usually at low doses. This is tardive dyskinesia. It's unusual at low doses, of course, because we are talking about symptoms that are produced by D2 blockage at the nigrostriatal pathway, which happens at high doses. Galacturia, amenorrhea, because of hyperprolactemia, of course, at high doses. Hypotension and tachycardia, of course, at high doses. A dry mouth, constipation, vision disturbance, and urinary retention for, muscarinic, anticholinergic. Sedation, decreased sweating, weight gain that may be unusual at low doses, sexual dysfunction, metabolic effects, and glucose tolerance. Okay, let's talk about some life-threatening or dangerous side effects. Rare neuroleptic malignant syndrome can happen. Rare seizures, rare jaundice and agranulocytosis. Increased risk for death of cerebrovascular events in elderly patients with dementia-related psychosis. Weight gain, it's unusual, reported but not expected, especially at low doses. Sedation, okay, common. Many experience and or can be significant in amounts, especially at high doses. Sedation is usually dose dependent and may not be experienced as sedation but as anxiolytic actions on anxiety and aggression at low doses, where Cyamemazine may function as an atypical antipsychotic, of course. We are talking about less than 300 milligram per day, especially 25 to 100 milligram per day. Okay, what to do about side effects? Wait. For motor symptoms, you can add anticholinergic agent, reduce the dose. For sedation, you can give at night, switch to an atypical antipsychotic, and you can weight loss exercise programs and medical management for high body mass indexes, diabetes, and dyslipidemia. What are the best augmenting agents for side effects? Okay, benzotropine or trihexyphenideine for motor side effects, benzodiazepines for akathisia, and many side effects cannot be improved with augmenting agents. Okay, so manage with that. What about dosing? The usual dose ranges from 50 to 300 milligram at bedtime for treatment of psychosis, and 25 for 100 milligram for anxiety, and the duration of treatment is of 4 weeks. For children ages 6 and older, 1 to 4 milligrams per kg per day. You can use injections 25 to 100 milligram per day. Dosage forms, we have tablets, oral solutions, and injections. Okay, tablets 25, 100, oral solutions 40 milligram per milliliter, and injections 50 milligram per 5 milliliter. Okay, how to dose? In psychosis, usual maintenance dose would be 50 to 300 milligram at bedtime. Maximum dose is 600 milligram per day, divided into 2 or 3 doses. After 2 weeks, you consider reducing to lowest effective dose. For anxiety in adults, the usual dose is between 25 to 100 milligram per day. Reduced dose if unacceptable sedation. Maximum duration of treatment should be 4 weeks. So it is not as anxiety treatment of by SSRIs or such. It's something like benzodiazepine effect of decreasing anxiety. Anxiety in children, usual dose is 1 to 4 milligram per kg per day. Okay, some dosing tips. Okay, it has conventional antipsychotic properties at originally recommended high doses. We said that conventional antipsychotic properties from 300 milligram to 600 milligram per day. Binding studies, PET studies, and clinical observations suggest that Cyamemazine may be atypical with low motor side effects or prolactin elevations at low doses, which is below 300 milligram per day. Clinical evidence suggests substantial anxiolytic benefits at 25 to 100 milligram per day in many patients. Clinical evidence suggests low extrapyramidal side effects, little prolactin elevation, yet demonstrable anxiolytic, anti-aggression, and antidepressant actions at doses below 300 milligram per day. Robust antipsychotic actions on positive symptoms may require dosing above 300 milligram per day. Low doses up to 100 milligram per day may be used to augment partial responders to other conventional or atypical antipsychotics, especially for anxiolytic actions. Treatment should be suspended if absolute neutrophil count falls below 1000 per millimeter square. What about overdose? It can cause extrapyramidal symptoms, of course, sedation, hypotension, coma, or even respiratory depression. Long-term use, some side effects may be irreversible, like tardive dyskinesia, no habit forming. How to stop? Okay, slow down titration over 6 to 8 weeks, especially when simultaneously beginning a new antipsychotic while switching. This is called cross titration. Rapid oral discontinuation of high doses of phenothiazine in psychotic patients may lead to rebound psychosis and worsening of symptoms. So be careful about that. If antiparkinsonian agents are being used, they should generally be continued for a few weeks after high dose cyamemazine is discontinued. Pharmacokinetics, the half-life here is 10 hours. About drug interactions, it may decrease the effects of levodopa and contraindicated for use with dopamine agonist other than levodopa. May increase the effects of antihypertensive drugs except for guanethidine. Those hypertensive actions, phenothiazines may antagonize actually. Okay. May enhance QTC prolongation of other drugs capable of prolonging QTC interval. Additive effects may occur if used with CNS depressants. Anticholinergic effects may occur if used with atropine or related compounds. Some patients taking a neuroleptic and lithium have developed an encephalopathic syndrome similar to neuroleptic malignant syndrome. So be careful. Epinephrine may lower blood pressure. Diuretics and alcohol may increase risk for hypotension when administered with phenothiazine. Okay. Other warning and precautions. If signs of neuroleptic malignant syndrome develop, treatment should be immediately discontinued. Use cautiously in patients with respiratory disorders. Use cautiously in patients with alcohol withdrawal or convulsive disorders because phenothiazines can lower seizure threshold. Do not use epinephrine in event of overdose, as interaction with some pressor agents may lower blood pressure. Avoid undue exposure to sunlight. Avoid extreme heat exposure. Use with caution in patients with respiratory disorders, glaucoma, or urinary retention. Antiemetic effects of phenothiazine may mask signs of other disorders or overdose. Suppression of cough reflex also may cause asphyxia. Observe for signs of ocular toxicity like corneal or lenticular deposits as for other phenothiazines. Use only with caution or at low doses, if at all, in Parkinson's disease or Lewy body dementia. Because cyamemazine may dose-dependently prolong QTC interval, use with caution in patients with who have bradycardia or who are taking drugs that can induce bradycardia like beta blockers, calcium channel blockers, clonidine, or digitalis. Because cyamemazine may dose-dependent prolonged QTC interval, use with caution in patients who have hyperkalemia and or hypomagnesemia, or who are taking drugs that can induce hypokalemia and or magnesemia, like diuretics, stimulant laxatives, intravenous amphotericin B, glucocorticoids, and tetracoxylides. Okay. Cyamemazine can increase the QTC interval, of course, so potentially causing torsades de pointes type arrhythmia or sudden death. Okay, so put that in your mind. You do not use cyamemazine if there is a history of QTC prolongation or cardiac arrhythmia, recent acute myocardial infarction, uncomplicated heart failure. If QTC interval greater than for 50 millisecond, or if taken an agent capable of prolonging the QTC interval. You cannot use cyamemazine if patient is taking celtopride, and if patient is in a comatose state or has CNS depression, and if there is the presence of blood dyscrasias, bone marrow depression, or liver disease, if there is subcortical brain damage, if patient has sensitivity to or intolerance of gluten, because tablets contain gluten, If patient has congenital galactosemia, does not adequately absorb glucose or galactose, or has lactase deficient because tablets contain lactose. If patient is intolerant of fructose, does not adequately absorb glucose, galactose, or has sugar isomaltase deficit. This is for oral solutions only. Oral solutions contain saccharose. If there is a proven allergy of cyamemazine, or if there is a known sensitivity to any phenothiazine. Okay, special populations. Use with caution in renal impairment and hepatic impairment. Cardiac impairment, cardiovascular toxicity can occur, especially orthostatic hypotension. Elderly patients may be more susceptible to adverse effects, so lower doses should be used and patients should be monitored closely. Generally, doses above 100 mg per day are not recommended here. Elderly patients with dementia-related psychosis treated with antipsychotics are at an increased risk of death compared with placebo, and also have an increased risk of cerebrovascular events. For children and adolescents, sometimes used for severe behavioral disturbance in children ages 6 and older, oral solutions is preferable to the other formulations, of course. About pregnancy, there is a risk of abnormal muscle movement and withdrawal symptoms in newborns whose mothers took an antipsychotic during the third trimester. Symptoms may include agitation, abnormally increased or decreased muscle tone, tremor, sleepiness, severe difficulty breathing, and difficulty feeding. Reports of extrapyramidal symptoms, jaundice, hyporeflexia in infant whose mothers took a phenothiazine during pregnancy. Phenothiazine should only be used during pregnancy if clearly needed. Psychotic symptoms may worsen during pregnancy and some form of treatment may be needed. Then atypical antipsychotics may be preferable to phenothiazines or anticonvulsant mood stabilizers if treatment is required during pregnancy. About breastfeeding, unknown if cyamemazine is secreted in human breast milk, but all psychotropics assumed to be secreted in breast milk, so recommended either to discontinue drug or bottle feed. About the art of psychopharmacology, potential advantages here for anxiety in patients with psychotic illness, for anxiety in patients with non-psychotic illness, and for severe depression we can use the drug of cyamemazine. Okay, potential disadvantages for cyamemazine, patients with tardive dyskinesia, children and elderly. And the primary target of symptoms is anxiety associated with psychosis or even anxiety alone. Okay. Another target symptoms: aggression, agitation, positive symptoms of psychosis, and severe depression. Pills. One of the most frequently prescribed antipsychotics in France, especially as a low-dose anxiolytic for psychotic patients. Okay, cyamemazine. French drug, I would say. Appears to have unique anxiolytic actions at low doses without rebound anxiety following discontinuation. Low doses rarely associated with motor side effects or with prolactin elevation. Recently discovered to be a serotonin dopamine antagonist with more potent binding of 5-HT2A and 5-HT2C receptors than D2 receptors, binding studies and PET scans. Low doses appear to saturate 5-HT2A receptors in frontal cortex while not saturating D2 receptors in the striatum, accounting for apparent atypical antipsychotic and anxiolytic properties at low doses. May be useful as second-line therapy in facilitating benzodiazepine withdrawal for those patients in whom substitution with another benzodiazepine is not effective or is not appropriate. So, here we have some suggested readings about this drug of cyamemazine. Okay, that's it.